today. Just so everybody knows, the event is being sort of live streamed so that people right across the province in all of our Schedule I membership hospitals have access to our discussions today. So why are we here? So I'll just say a few words about the AGHPS. So the Association of General Hospital Psychiatric Services is an organization that represents all Schedule I facilities in the province of Ontario. We have a number of mandates, but the mandate that is most relevant for today is we wish to create forums so that we can share innovations, best practices, standards between our various hospitals across the province so that we can facilitate standardization of care and ideally standardization of best practice care and any kind of new and exciting sort of innovations. I think that we would probably all agree that in the world of mental health and psychiatry, there is sadly probably too much variability, too much variance. We all treat the same patients, and we all across our province and across our hospitals provide our service slightly differently, have slightly different resources. So what happens in terms of the patient experience is going to vary much more than it should, depending upon which hospital emergency department they happen to walk into. I would suggest that variability is probably even greater for the diagnostic group that we are here to speak about today, individuals with a diagnosis of schizophrenia, that there is probably far too much variability in terms of how individuals are treated and the care that they are offered right across the province. And that's really the focus of our discussions today. So we have 3 panelists to help discuss what are some of the evidence-based best practices as articulated in the literature and as are articulated in the Health Quality Ontario quality standards that have been released a couple of years ago, amongst other standards as well. And our hope is that we can both sort of share what our best practices, but also kind of look at, what sort of underpins some of the variability? What is it that we need to do? Is it education? Is it resources? What is it that we need to do so that we can better disseminate and sort of change and diminish some of the variability that exists among us? So that's kind of a bit of background on AGHPS and why we are here. Maybe I will turn it over to Dr. Mehta so that he can introduce our panelists and get the discussions going.
Thank you, David. When you call me Dr. Mehta, I feel like Dr. Brenner. So I'm not there yet. So thank you so much to AGHPS, June, Fevan, and all the staff for arranging this, and to sponsors, Lundbeck, for kindly, and Jensen for kindly supporting this event. It's a pleasure to host this event. When AGHPS was looking for a place, so I thought that we'll host it. We'll get all the credit by doing nothing. Food will be provided. Speakers will come, do their talk, and you don't have to listen to me. This is very good. So I'll just invite our panelists, introduce our first panelist, Dr. Shami. Dr. Shami, everybody knows. If you work in schizophrenia, you know Dr. Shami. If you don't know Dr. Shami, then you have to reconsider what you're doing. Okay? So Dr. Shami is a psychiatrist with an interest in psychopharmacology and is the management of psychotic disorders. He's a clinical educator affiliated with Ontario Shore Centers of Mental Health Sciences in Whitby, Markham Stouffville Hospital, and UFT. So he is going to educate us and talk about use of clozapine. You want to come here?
So thank you all for this opportunity to speak here. I think that, before I get into the issue of clozapine, I'm going to start with some general remarks, and that is that, like all medical disorders, we have to start first with doing a proper assessment and then coming up with a management plan. So schizophrenia requires a comprehensive assessment, good diagnosis, attention to differential diagnosis, and treating the whole patient, which means treating not just the psychiatric disorder or not just one psychiatric disorder such as schizophrenia, even though that might be the primary diagnosis. It's treating comorbid medical conditions. It's treating other comorbid psychiatric conditions, such as the commonest comorbid diagnosis, psychiatric comorbid diagnosis with schizophrenia is anxiety. We all recognize depression as having common comorbidity with schizophrenia, but the commonest symptoms actually are anxiety symptoms rather than depressive symptoms. And so if you don't treat anxiety, you don't treat depression, the outcomes are a lot worse. So before we go into saying somebody's treatment refractory, I think we need to step back a little bit and make sure that we've done the physical exam, we've ruled out medical conditions, general medical conditions that might be part of the presentation or may require treatment independently. We also want to encourage smoking cessation. We want to do a metabolic assessment. And that's what, as clinicians, all of us are doing in our day-to-day practice. And that's exactly what all the guidelines recommend as well. That's exactly what Health Quality Ontario recommends in its treatment plan. That we need to offer every patient with schizophrenia deserves not just optimal psychopharmacological treatment, but requires optimal psychosocial treatment. So evidence-based psychotherapies are critically important. Family therapy, family intervention is important. Access to care is important. Lots of our patients struggle with getting appointments to see a psychiatrist. They fall between the cracks. Patients are discharged from hospital without any proper follow-up coordination. So just having access to health care and having eligibility for OHIP doesn't guarantee that you either receive care or that you're getting the best care. So I think that one of the issues that's come up recently is that maybe in all of medicine, we should be paying more attention not just to doing things in a systematic way, but also looking at accountability. And that accountability might include how closely are we following the guidelines? How closely are we following evidence-based practices? And are we actually doing measurement-based care? So some of you, I know, recently we had a program here, staff from South Lake, and Dr. Mehta was there as well, in which we spoke about the benefits of measurement-based care. And the reason why we want to use scales and the reason why we want to be sure that we're not ignoring untreated symptoms is because if you pay attention to it, then things are going to improve. Now, Lord Kelvin, who was a Scottish mathematician and physicist, he actually formulated the second law of thermodynamics. And one of what Lord Kelvin said was that if you don't measure it, you can't improve it. So Lord Kelvin was the one who came up with absolute zero, minus 273 degrees Celsius. You might remember from your high school days or something like that. So essentially what I'm saying is that if you don't treat substance use problems, you don't treat marital issues, you don't arrange housing, you don't arrange follow-up, your care is going to be poor. What do we do in terms of our pharmacological strategies? Essentially what we do is we do sequential trials in all of medicine. So you try what you regard as first-line treatments, and with any intervention, there's three possibilities. You can get a response, you can get a partial response, you can get non-response, or you can get worsening. Those are the four options you have. If you get a partial response, then you want to wait, give the treatment more time to exert greater therapeutic effects. And if there's non-response, then you want to consider changing the treatment. So in other words, this first strategy is optimization. The second strategy is substitution. And if you've tried one or two trials, then what can you do? You can consider augmentation, or you can consider combination treatment. So the difference between augmentation and combination, it's a little bit of hair splitting. If you use two compounds, two molecules, two drugs from the same therapeutic class, such as two antidepressants if you're treating depression, two antipsychotics if you're treating psychosis, two anti-anxiety agents, anxiolytics if you're treating anxiety, etc., then it's called combination. If you add lithium to an antidepressant, that's seen as augmentation. If you add a benzodiazepine or a mood stabilizer to an antipsychotic, that's seen as augmentation. So you have to do these things sequentially. You've tried 1, 2, 3 trials, whatever the number may be of first-line agents. Then you have to step back again and do another analysis where you say, is the patient not improving because they're not taking their treatment? Because non-adherence is a big problem. All of medical disorders, 50% of patients do not take their treatments as prescribed. So non-adherence is a big factor. And the way to address non-adherence in schizophrenia, psychotic disorders, is to encourage the patient to go on a long-acting injectable. And Dr. Robinson's going to be talking about it. And Dr. Namey is going to be talking to you about cognitive behavior therapy. So with the pharmacotherapy part of it, if the big issue is, are they untreated conditions? Are we treating all the, providing the interventions the patient needs? Then the fork in the road is, if it's non-adherence, you want to go the long-acting injectable route. If it's true treatment refractoriness, you want to consider clozapine. And Health Quality Ontario, among all the quality statements, there's only 2 statements that relate to pharmacological treatment of schizophrenia. The first is that every patient should be considered for and offered long-acting injectable treatment. And the second pharmacological recommendation quality standard is every patient who has failed 2 trials of antipsychotics should be offered and considered for a trial of clozapine. Those are the only 2 psychopharmacological recommendations in Health Quality Ontario. This was published in 2016, and you can actually look it up, www.hqontario, Health Quality Ontario, hqontario.ca. The latest Canadian practice treatment guidelines on schizophrenia are published in 2017. 2017, September, I think, in the Canadian Journal of Psychiatry. So with treatment refractory schizophrenia, that is people who failed multiple trials of first-line drugs, what we know is over time, individuals who keep having relapses and keep having exacerbations, acute psychotic episodes, become less and less responsive to treatment. It takes longer and longer for them to respond to a drug. And it takes higher and higher doses sometimes for them to respond to treatment. And there is some degree of toxicity to the brain, potential for brain atrophy, potential for ventricular enlargement, potential for increasing cognitive deficits, etc. And so we want to prevent that. So in terms of the barriers, one of the barriers with clozapine is the need for the lab monitoring. And the other concern is that lots of physicians are either not familiar with it or they consider it very difficult to offer this care. So for whatever reason, even though roughly over time, 25% of individuals with schizophrenia will become treatment refractory, only about 5% of individuals in Canada are on treatment with schizophrenia. Similarly, it's really disappointing that the number of individuals on a long-acting injectable antipsychotic in Canada is around 3% or less than that. So why is it that if we know 80 to 90% of individuals will stop their oral meds or be only partially adherent, why is it that we don't consider them for injectables? Similarly, the gold standard for treatment refractory patients is a trial of clozapine. Why is it that we are so hesitant and not meeting the guidelines. The other thing I want to tell you very quickly is you get an early signal as to whether somebody will respond or not respond. And that is that there is very good data that response at 2 weeks after you started medication and they're at the therapeutic dose, the response at 2 weeks tells you whether the person will be a responder or a non-responder at 12 weeks. So if there's no response at 2 weeks, there's about an 85% probability that if you continued for a further 10 weeks of treatment, the person will continue to remain a non-responder. So that's called negative predictive value, and it's around 85%. The positive predictive value is not as good. If somebody shows an initial response at 2 weeks, there's only about a 55% probability of response at 12 weeks. The difficulty that clinicians have is in ascertaining, is the person a complete non-responder at 2 weeks, or are they a partial responder? If there's a little bit of improvement, you don't want to give up on it. You want to continue the treatment for longer. You want to optimize the dosage, increase it, or decrease it if they're not intolerant of it. But if they completely show absolutely no signal of improvement at 2 weeks, you're best to switch to an alternative treatment. I think I'm running out of time, so.
Over the time. Now to be fair to each speaker, Dr. Shami. Thank you. You covered all the introduction, so I'll just introduce the next speaker, which is a very close friend of mine, Professor Farooq Naeem. Professor Naeem is a staff psychiatrist in schizophrenia program at KMH, and he's a professor of psychiatry at UFT, and those of you who are interested in CBT, he's the sort of guru in cultural CBT. So I'll just invite Dr. Naeem.
Thank you. So I'm going to set my stopwatch so you don't give me that look you gave with Shami. No, you're doing a great job. Thank you. CBT for psychosis is started in the UK 20 years ago, unlike CBT for common mental disorders, which is a very American thing. So I think it's a very nice day to talk about CBT for psychosis on a lovely rainy day. So it's not really, so there are similarities and differences. It's not diagnosis focused. So like CBT and for other problems, is symptoms focused. The other thing is it uses biopsychosocial model really heavily, especially the biological, so more acceptance of biological model. We're going to talk about just 3 things within these 4 or 5 minutes. One is the evidence, the second is the barriers, and the third, the way forward. So quickly about the evidence. The Health Quality Ontario, as Dr. Shami mentioned, has recommends CBT for psychosis for a patient with schizophrenia. And both the inpatient and the outpatient or the community guidelines, they do that. And recently, the health technology assessments, Health Quality Ontario's, they issued this technology assessment, which basically is about the cost effectiveness and about the efficacy. And so they pooled 13. I think they found 78 meta-analysis. I think, as far as I'm aware, more than 50 RCTs have been published on CBT for psychosis. And so they found 78 meta-analysis, and they selected 13. And they found that CBT for psychosis is effective and cost-effective. They looked at the physicians, whether it should be physicians or non-physicians. There's a huge question in Canada, and I think I'm sure you're aware of the recent it's news yet, but people are looking at physicians giving, or the government is actually looking at physicians' delivery of CBT. So the difference is actually interesting. So if for 5 years, the cost will be $15 million if the psychiatrist or physicians give CBT for psychosis, and $30 sorry, 35 if physicians give, and 15 million if the non-physicians give CBT. So I think that's an easy thing to okay. Other places, the national organizations like NICE in UK, Scottish guidelines, NICE in England, Scottish guidelines in Scotland, Royal Australian and New Zealand guidelines, American guidelines, Canadian guidelines, they all recommend CBT, but there are a lot of differences too. Even the NICE and the Scottish guidelines are different. So the NICE guidelines say CBT individual for everyone. And the Scottish guidelines recommend mainly for treatment-resistant schizophrenia. It's interesting because more recent publications, actually, especially the recent paper on a big RCT, we didn't really find any evidence for CBT for psychosis to be effective for treatment-resistant. And these were non-responders to clozapine. So that's a question: when somebody's non-responder to clozapine, are they also non-responder to psychotherapy? And I'm not going to really go into the details of the meta-analysis. There are issues we're discovering more in the more recent meta-analysis. The effect is decreasing. But that's the general kind of thing that happens when something new starts. There are usually expert therapists, and the smaller numbers. So I'm not going to go into the stats, but if you are interested, I can explain. The barriers. The first barrier, obviously, is money, and that really, is true that it drives everything. Anything, I'm actually thinking these days, should we change the biopsychosocial model to? Am I over? Okay, so why is my okay? No, I'll try to do it within 4 or 5 minutes. So the first thing is really resources, and that. Sorry, I was saying. So I sometimes think really we should think more of a biopsychosocioeconomic model of illness, because economic factors are so important and independent even of the social factors. So I think we need to modify and think more about including economic in the model that we use for understanding of mental health problems. The second thing is access to CBT psychosis. In Kingston, Tariq Manshi and colleagues, and I was part of that, but I didn't really do much. That's the good thing about being a professor. You don't have to do a lot, and you get your name on papers. So what we found, both clozapine and depot, really, so they actually looked at the quality standards in Kingston General Hospital, and they found very low number of patients who were receiving these or meeting these criteria. But for CBT psychosis, it was actually 9.8% of the patients who received that. But having said that, even when CBT psychosis is available, so Southampton, where I was trained by, so I was trained in CBT for many years, and the system is different, so there's more years of training, and you don't have to think about your billing because you're on a salary. So I was trained by David Kingdon, who's one of the pioneers in CBT psychosis. And anyway, so David conducted this survey, it was like 10, 15 years ago. And what they found, while, Southampton is one of the centers where there's so much CBT psychosis. When I was in training, we had difficulty in finding patients. So, however, 20-30% patients did not receive CBT for psychosis. And when they explored the reasons, so the mental health professionals were not convinced that CBT psychosis works. They thought they're not suitable for all kind of reasons. So even when, and we see this with CBT in general. So this is the kind of the attitude of professionals is really important. And I think the other thing is the political will. the awareness. You just let me know when you have 1 minute left, sir, and I'll stop. So the other thing is if you think about really, unlike depression and anxiety, people with schizophrenia go down that slope really quickly. There's no really voice of these patients. So it's interesting that, how many antidepressants we have. We don't have any antipsychotics. So, and I do this MAPS clinic, which, in KMH, so it's mostly treatment resistant, and you guys know. So it's really interesting, apart from the shotgun therapy, I also noticed that most patients actually, 80% are from outside of KMH, and most of them have not seen one patient who actually received CBT psychosis. So quickly was the way forward. I think CBT can be given in different forms, so expert therapists, a group, but in very cost-effective ways. So, for example, guided self-help. So I and David developed and tested a guided self-help, and we're looking at applying for bigger funding to do bigger RCT. So guided self-help, low-intensity CBT for psychosis, and non-physicians, so people, who are case managers. So I think all these people, that's going to be really the way forward if we want to give people CBT for schizophrenia, and the political will. And I think the reason we had the CBT structured program is because the political will. It's because I moved here 5 years ago, and I started reading all these newspaper articles, and and everybody on TV was talking about this. So that created that environment in which the government launched CBT structured programs. So there is a need for that political will, and there is a need to help people understand how disadvantaged this group is. Thank you.
Our last speaker for today is Dr. David Robinson, Dave, and he's again a good friend, and he's a psychiatrist practicing in London. He is a lecturer in psychiatry at University of Western Ontario. He trained our current chief, Dr. Memapur. So Dr. Memapur is a ex-trainee of Dr. Robinson, correct? Is that correct? You trained Marty, right?
Yes, I did. I absolutely did.
And those of you who don't know, he is the lead author for the Diabetes Canada Guidelines, the mental health chapter. So please welcome Dr. Robinson.
All right, thank you. Somewhat like medical school, I think my invite today was a clerical error. But I'm happy to be here and really honored, and I want to thank the people that have run the program for including me on the list. I am a general adult psychiatrist in London. I spent 22 years in general hospitals, and I charitably refer to myself as the Swiss Army tool of Canadian psychiatry because I've been a bunch of places and done a bunch of things. And currently, I think the expertise I bring is I've seen both sides of the equation, the inpatient and now the outpatient part. I'm going to structure my comments in 4 major areas. And I first want to talk about depot clinics. Now, I started my residency in the late 80s, and we had depot clinics. And I got a decent enough exposure to it, but they weren't really emphasized that strongly. And the time that I spent there was actually not really that interesting. And the reason for that, in hindsight, is that the people were all stable and they were doing well. And in your residency, you want to see the pathology. You want to see really ill people. And people in those clinics were actually so stable that you were talking about the injection, and we had a few ones to choose between. And I just think part of this problem is that these clinics have very stable people. When you want that learning exposure, you look elsewhere. Secondly, these compounds were actually dissolved in an oil, and they really did have a depot. There was just this blob of oil with the medication that would dissolve slowly over 2 weeks or 4 weeks. The technology now is quite different, so I don't know whether the term depot clinic is still properly applied, but we'll call it an injection clinic. I think one of the issues is that residency options have become very enticing. You can see some subspecialty wizardry in all sorts of areas, particularly in Toronto, and these clinics just don't really shine as a great opportunity. Just to sum this section up, there was a long period of time where nothing was happening. Risperdal or risperidone wasn't released in Canada until '96. It was 2004 before Risperdal Consta came out. So I think there's a whole generation of psychiatrists now that didn't get exposure to clinics, lost interest, didn't find them all that interesting, but graduated and now practice without really a feel for the benefit of these programs. I'll move on to the evidence of the effectiveness. I could have and have given hour-long presentations looking at studies about just the benefits of people being on an injection. The injections actually have a better pharmacologic profile than the oral medications do. Pharmacokinetics is better. Side effect profile is actually different when it's injected as opposed to swallowed. Simply put, they work better even if for no other reason than they're there all the time. One of the benefits of going last is that my two esteemed colleagues have given half of my talk, so I've been trying to cross out stuff I don't need to say. And being a male in his 50s, I'm very phobic of the letters ED, so I'm going to talk about ER instead. But ER visits are down, crisis calls are down, admissions to hospital are reduced, length of stay is reduced. Everything gets better with these injections. They can change the course of the illness if they're given early enough. So as Dr. Shammy said, if we get people either on an injection or on clozapine early, the trajectory of that illness is different, and that is the time to actually treat it. I'm going to quote my friend Dr. Toba Olabuka from Calgary, very educated guy, has done a bunch of programs and advanced courses in psychiatry, but will freely admit that he has never finished a course of antibiotics. And Dr. Shammy said really what the abysmal oral adherence rates are, and that's across the board. You really only see adherence rates do well when people are in pain or actively suffering. The brain doesn't hurt during a psychotic episode, and the adherence rates are really quite pessimistic. And I'll just leave this section by saying that there was an article from Dr. Stipp in Quebec showing a $30,000 per year per person saving when people were on injectable medications. So the current situation, I think, is really quite favorable. We've got significantly different molecules that are available and very passionate pharmaceutical companies that are sponsoring all sorts of educational and clinical initiatives. Then I'll sum up with what I see as the challenge. Dr. Shammy already said what the low adoption rates are for Canada. I think we are the worst in the industrialized nations for putting people on these injections. I think that residencies underemphasize this during their training. The CMHA London Middlesex, where I work, does a significant amount of injection work for the LHSC, the acute care hospital. We don't see the residents there. They don't show up. They don't learn how to give the injections or how to finesse these things. Some psychiatrists, I think, have a personal bias against injections. There's a list of reasons for that I think are beyond the scope for today. But prescriber bias, I think, is rapidly becoming one of the more obvious things that hopefully can be addressed. The true prevalence of needle phobia is grossly over-exaggerated. I think that some people are just awkward about starting that conversation with the people that they treat. We have some psychiatrists that don't really come out to local CMEs, and they don't get the benefit of speaking with their peers and the influence and the endorsement from things that work that presumably would be free or freer of commercial bias. Some of them just don't come out, and that they're not really sharing their stories. And as Dr. Shammy said, the Ontario Health Quality Standards recommend that people should be offered an injection, but there's a lot of finesse that actually goes into how that offer is made. And I would say, as a way of summary, that any initiative that trains staff, that gets more injection staff, or frees up any resources for injections, it will be well worthwhile and will pay a dividend very shortly. And the last comment I'll make is that I think that Dr. McCoy from the original Star Trek would have said something like, "Damn it, Jim, we need better technology." And you never saw anyone take a pill in Star Trek, right? They always had the hypo spray. We have that technology now, and I think it's time for us to use it.
So thank you very, very much. I loved sitting there watching all three of their heads explode because they all had so much that they wanted to say, but they knew that they had limited time, which was really quite fascinating. So to get the discussion, keep the discussion going in the time that we have, I don't know about everybody else in the audience, but as I sit here listening, I'm actually feeling rather depressed. What we've heard was some excellent and very eloquent and very strong statements on what is best practice in the treatment of this very, very significant illness with such incredible morbidity in patients and families that starts at such a young age. And yet what we also heard was, we're doing a lousy job. Our utilization of clozapine in treatment-resistant patients is relatively poor. Our utilization of LAIs is relatively poor. Our accessibility and availability of CBT therapies, and probably other therapies as well for these patients, is relatively poor. Would we say that about any other area of medicine in this country? If we were talking about cancer therapy or cardiac disease or musculoskeletal disease? Probably not. We have such incredible variability, so that's why I'm finding myself feeling rather downcast as I listen to these incredibly entertaining and eloquent and strong speakers. So I'll put it back to the three of you and ask the question, where do we go from here? I mean, do we need to modify the changes of psychiatrist behavior? Do we need to change the behaviors of our institutions, our hospitals? Or do we need to change the behaviors of our political system? Where is the greatest bang for the buck? How do we push this bar forward in treating this seriously ill population? So.
I think the answer is all of the above. So I think that there's many problems with the healthcare system, and one of that includes the fact that a lot of trained psychiatrists do not want to treat the seriously mentally ill, and part of the problem is that the healthcare system seems to be better for physicians than it is for patients. That's my opinion, because physicians have the choice of operating in a hospital, of being in a clinic, of doing a call or not doing call, choosing what diagnostic category within mental health that they will treat, etc. And I think it's problematic because, as as already Dr. Naim mentioned, that CBT can be effectively delivered by non-physicians in a much more cost-effective way. There's been a debate as well in the Globe and Mail, a public debate between Norman Doidge, who was advocating, saying that essentially psychotherapy should be funded by the government and no restrictions made. And there's a rebuttal from Sunnybrook, that I'm having a mental block for the name now.
Oh, yes.
Any case, he's a CBT specialist in psychiatry. He used to be the training director for the psychiatry.
Ari Zaretsky.
Ari Zaretsky.
Yes.
So Ari Zaretsky has done a rebuttal again in the Globe and Mail, and you can Google it and see, saying that no, if the government's paying for this or if private insurance paying for it, then you want the most cost-effective treatments, and you want the most seriously ill people to be treated first, not the most seriously ill people are waiting 3 months to get to see somebody, and if you're worried, well, you can get in tomorrow. It doesn't make sense. There's no other branch of medicine in which the most seriously ill people have to wait longer than someone who may not be as impaired, may not have as much need for care. So I'm going to let my fellow panelists
say something that's a little bit less controversial.
It's always difficult to follow Dr. Shami. He makes all the good points. I'll say this, that I think, unfortunately, this illness robs people of so much that they end up just not being good advocates for themselves. If, for example, there was an organization that wanted to get more attention and more funding for breast cancer, and they had a march on Queen's Park, it would be successful, it would be televised, there'd be a lot of sympathy, they'd probably get a result. I'm not trying to be funny with this comment, but imagine if there was a large group of people with schizophrenia that descended on Queen's Park, it's less likely to get the result that they're looking for. So their families don't really know what to do. It's a complex illness. There are several different facets of it that I don't think they understand that well. One positive thing is in the last couple of years, I've had some people actually come and ask me for the injection. So the word has gotten around, and I think the most important endorsement comes from people that are already on it. So I've been trying to look for ways, respecting people's confidentiality, to link up people that are on the injection with people that are considering it, and that's, I think, been a very powerful endorsement and some cause for optimism.
Thank you. I think even with the most, before that, I think we can't really say it's physicians or other health professionals or governments. It's a kind of part of the bigger system, isn't it? It's a whole system that really needs to improve. And an interesting thing is even the best possible intentions, things can go wrong. So for example, if you think about the asylums being closed, what happened? People were on the streets. Although we then had, and we still have a lot of people in the streets who actually would have been, I mean, I live in downtown Toronto and I see these people, you know, and the same thing I saw in Southampton, so in UK. So all these people, so we did that with best intention. I'm not saying we should go back to asylums, but I'm just saying we need to think about the side effects of the good intentions. And about, it's also about kind of constantly changing, reflection on what we're doing as a system. One big thing I find in North America when compared with the European psychiatry, there are many differences, many similarities, but one is the emphasis on biological psychiatry and biological research. There's more money, I'm sure you know, that goes into biological research. And I mean, I never heard of ECT, but I've seen a lot of patients actually receive ECT because nothing else is working, and there's no evidence. The other day, Benoit told me I'm the only psychiatrist who does research on psychosocial interventions. So I think really it's about looking at the bigger model as well, looking at all the different aspects. It's about thinking about the overall system. We can't just exclude ourselves, you know, okay, it's the government. No, it's everyone.
So thank you for those very thoughtful comments. So I want to throw another idea out. When we speak about the poor utilization of some of these treatments, we haven't really spoken much. I mean, so we know many of our patients, if we ask them to take clozapine, they'll say no because they don't want the blood tests, or they say no because they're concerns about side effects of, you know, weight gain and metabolic disturbance. Many of them will say no to LAIs because they don't want an injection, they don't want a needle. So we haven't really spoken about the question that's really not very well addressed, in my opinion, in the HQO guidelines, the question of capacity assessment, question of substitute decision makers, and the question of the utilization of community treatment orders. I was almost a bit surprised that those weren't addressed in the guidelines. I wonder if you have any thoughts about those issues.
Sure. I think there's two issues. One is that when we look at the low numbers in terms of people on evidence-based treatment interventions, the issue is not just refusal, because a lot of the time patients say they were never offered these treatments. Nobody had the discussion. Or it's sequenced so late that maybe you've lost that window of opportunity during a critical time period when people would have been more responsive to the intervention, because years have gone by and there's more and more treatment refractoriness that's been incurred as a result of neglect of offering the treatment. So when we look at Health Quality Ontario actually recommends two things, that you need to look at process indicators, the percentage offered and percentage receiving the most evidence-based interventions. And if you look at both, it's not that a high number were offered and only a few were receiving it, it's that low numbers were offered the treatment. And like everything else, you need clinical skills. I mean, all of life, it involves some degree of persuasion. As Woody Allen said, 95% of life is just showing up. So, getting people to come, keep their appointments, and then having the conversation, and it doesn't start with the first refusal. It's a process of engagement. It's a process of education. And then there are lots of clinical pearls and tips that we can share among colleagues, and people get better at figuring out how to present the information, how to encourage the dialogue, and how to convince patients to take the most evidence-based treatments. I mean, the bottom line is, if you ask a physician or a nurse or anybody, any healthcare provider, what would you want if your family member had this disorder? Most people would say that they wanted the best treatment, they wanted the most evidence-based treatment, and they would, go to hell or cross high water in order to get access to that best or optimal treatments. So why is it that if we want this for our families, why aren't we offering it? Why aren't we fighting to convince patients and families about the treatments that will work and the treatments that work the best? So I think, we still have to challenge ourselves. The other issue that I would say is the rates of use, for example, of long-acting injections has dropped in Canada. So it was around 35% around 1990, 1992, when a survey was done. Actually, Gary Remington published a paper with Martha Adams, early 90s, looking at, it was around 35%. It was around 65% in Europe at that point. And now we're close to 3% in Canada, and it's come down in Europe as well. It's around a third. So that's the other issue is, if the base rate of acceptance, when we only had the old first generation or typical antipsychotics, if the base rate of acceptance of some of these interventions, such as injectables, was about a third of the population, why is it at 3%? So it tells me it's not that suddenly people have developed needle phobias and are refusing treatment. And of course, often there'll be a huge guy with multiple tattoos who comes in and says, I'm scared of needles. I mean, come on. The thing is that we can't take the no at face value. We can't just say, well, I've done my job, and I'm going to move on, and I'm going to keep prescribing meds that are not working, whether it be oral meds that the person's not taking, or they be treatments that are ineffective due to treatment refractoriness. So I think we still need to do more in that regard.
I'll just add a little bit to that. I want to give credit to the pharmaceutical companies. You may not be aware of this, but there is currently no injection available in Ontario that's not covered on ODB. They've done a magnificent job of making all of their injections, so that's not a barrier. And I think what Dr. Shambi was saying, that there is, I think I would like to see a change in this. This is sort of what Nova Scotia is doing now with organ donation. You have to give a good reason why you don't want to donate your organs. The null hypothesis, or the assumption there for the rest of the country, is that you don't want to, you have to sign up for it. I'd like to see something where people have to give a pretty good reason why they don't want to be the injection, because just the very powerful amount of data. The adherence rates for medications taken orally are very poor. Everything gets better on the injection. And as I said, we have very different molecules to offer people. I'd like to see a system put in place where they have to have a good reason for declining it, and to make it the expectation.
I think if you put it in a wider context, the issue is really the Use of Mental Health Act. I think that's really the important thing. So first of all, I'm not aware of any other treatment guidelines which use the Use of Mental Health Act. So none of, I know nice Scottish, Royal, Australia, no guidelines talks about this. It's actually really interesting, and I was thought about this thing just now. You mentioned this thing because really, if you think about people with schizophrenia, Use of Mental Health Act is a major intervention, isn't it? Why we don't talk about this thing? I think that historically there's there's risk of aversion. We know the Abuse of Mental Health Act, and so that might be a kind of reason. The public pressure again, I think. So I'm not defending or offending anyone. I'm just kind of, just sharing my thoughts. And but I think, to your point, I think it might be a reason because people are becoming more aware. People are becoming more anti-psychiatry, which again, really, we should think why. Why people are becoming more anti-psychiatry? Why the compliance rates are dropping? Is it because the law has more teeth than the mental health law has? You see, so I think these are really important questions, how we use the Mental Health Act. So you can't really, think about the depot. So it's not really about, and I know that you were just, putting it in a light way, but it doesn't really matter if you have tattoos or not, because, I'm very sensitive to injection, and honestly, I become tearful when I give blood for injections. It has nothing to do with it, but it has to be with compulsion, with a reason, and we have to think about the lack of insight. So Mental Health Act really needs to have more teeth. I see more people here, compared with the UK, more people who go on Form 2. And so the 72-hour detention is actually very high rates, alarmingly high rates, but the continuation of detention is very low in Canada. So that's really something, this is a food for thought really, why that's the case. CTOs, I see very small number of patients in CTOs. CTOs are amazing things to improve compliance. And in the end, really, you need more psychotherapy, you need compliance therapy, and that's true.
Thank you very, very much for those thoughts and that discussion. I feel like we've really sort of put our toe into the water of such an incredibly important topic. It is such an important topic from an educational perspective, from a physician, psychiatrist practice perspective, from the way that we organize our resources as hospitals, and from the way that we think about mental illness in this population from a societal, political, advocacy perspective. I wish there were a few politicians in the room to listen to the discussion that we've had here today. I realize that we are running short on time, so on that note, I'm going to invite up June Hyland, who is the Executive Director of the AGHPS, just to say a few closing remarks. Please, June.
Thank you, David. So I am June Hylands, Executive Director, AGHPS, but I'm here to thank on behalf of Dr. Kozerginski, who is the President, the board members, Dr. Mehta is a board member, all the member hospitals, for their interest and support in getting something like this started. The AGHPS is really pleased that in addition to the people who took their time to be here on site, who it is being live broadcasted to any and all Schedule I hospitals across Ontario. It will also be uploaded so that you can use it as a reference on our website in the future, so we're quite excited about that. We'd like to thank our expert panel, Dr. Shami, Dr. Naeem, Dr. Robinson. Dr. Mehta, as I said, we'd like to thank you for hosting, and South Lake Regional Hospital is a delight to work with. I'd like to especially thank Fevin Geberhert, I'm not sure I said your name right, for internal logistics. David Weingarten is their internal AV person who was so gracious and worked with MCR to make sure the technology was working properly. And then I'd like to thank Lundbeck Canada for the unrestricted financial funding to be able to host such an important event. We hope that this is the first of many, and as David said, we've really just scratched the surface. So the AGHPS will be looking at this in the future. So thank you very much for everyone's participation today.